Dr. Nishaathussein Naushad. He is working as a Dar es Islam Hospital, Tanzania. So I think I will request Dr. Kapoor to introduce the speaker.
So Nishat is a young surgical colleague from Tanzania. He joined us in the Jaipur Surgical Festival recently. He has been attending the Jaipur Surgical tutorial classes very regularly. He is very keen to come to India for about a year for further training. So I would like to request all my colleagues who are here to please entertain his application as and when it comes, including Dr. Chetan, Dr. Dash, because I would want him to spend about 3 months each at 3 or 4 centers so that he can get exposed to the special areas of interest which we can offer to him. In fact, one of his other colleagues from Tanzania, Dr. Vihar Kotecha, is already in India. He is with Dr. Beju Sanadhipan at the moment. He's going to join Puneet Dhar for some time. And if he wants, then I will request either Dr. Chetan or Dr. Dash to enter.
Sure.
And so Nishat again volunteered that he would like to speak, and I was very happy. And I think this is his first presentation in the masterclass. And I would request all the senior colleagues to please convey to him personally how to improve his presentation further. So Nishat, thank you very much for volunteering to make a presentation. Please start.
Thank you very much. I'm very grateful to Professor Kapoor for giving me such an opportunity to present in such a prestigious forum. And I hope I can do justice to the topic. It's my first time presenting on this forum, so for any, please correct me and guide me further. Thank you very much. So is my screen visible, sir?
Yes, please do. And
Yes,
you
okay,
don't have to say that. That is also our job as your teachers, that wherever we think you can make it even better, we will definitely point out to you. All the senior colleagues will do that. Don't worry.
So today, the topic I've been given is corrosive injury and the risk of cancer. So this is going to be my outline. I'm going to introduce the topic briefly, and then I'm going to talk about certain nuances in the diagnosis, the management, and the prognosis. And finally, I'll summarize it. So esophageal cancer is one of the late complications of prostate stenosis. Any ingestion of corrosive, acidic, or alkaline injury, especially the severe, moderate to severe cases which cause stenosis, increase the risk of esophageal cancer by about 1,000-fold. However, the literature is not very strong to convey the exact risk of esophageal cancer. The incidence is reported to be between 1 to 4%, and the most common histological type is squamous cell carcinoma, and mostly in the middle part of the esophagus. The occurrence from the time of injury takes about 3 to 4 decades. However, in literature, it can be much more earlier or much more later. The exact mechanism of cancer development is unclear. However, because of the stenosis and the narrowing, there is stasis, which leads to chronic inflammation and chronic irritation of the esophageal mucosa, which increases the risk of development of esophageal cancer. Also, repeated endoscopic interventions and dilatations lead to ulcerations and can also lead to the cascade of development of carcinogenesis and development of esophageal cancer. In literature, the first incidence of esophageal cancer related to prostate injury was reported in 1904 by Teleke in a 22-year-old male who had a history of acid ingestion at the age of 2 years, and the esophageal CA was found at autopsy in the mid part of the esophagus, which had perforated into the left bronchus. Thereafter, many studies have been reported to show the association. However, because of the long duration from the injury to the occurrence of esophageal CA, it takes a long period, decades. Follow-up programs are not very well formed, and because there might be also loss of follow-up, and in poor and developing countries, some of the cases might even go unreported. So the true incidence is still unknown, and therefore the need of national database. In the literature, the shortest duration of ingestion to occurrence is reported by Rohit Jain et al. in a 14-year-old Indian boy who develops squamous cell carcinoma with cervical lymph node metastasis just 1 year after the injection of corrosive agent. So acoustic stenosis of esophagus depends on the product, the amount, the concentration of the ingested material, also the intent. I'll not go deep into that. This has already been discussed. But Kochar and colleagues suggested that esophageal acid ingestion might be associated with a lower risk of development of carcinoma than alkali ingestion. And this is because alkali tend to stick to the wall of the esophageal more because they react with the proteins and lipids on the wall of the esophagus, causing saponification and effective necrosis involving the deeper layers of the esophageal wall and more prone to severe strictures and therefore increase the risk of esophageal CA. However, when the concentration and the amount is large, this difference becomes negligible. Raul et al. In his study showed that squamous cell carcinoma was diagnosed in 80% of cases as the most common histological etiology, others being adenocarcinoma and uh, other forms. And the most frequent age of occurrence was between 40 and 70 years, mean being 59 years. Coming to the diagnosis, the diagnosis of corrosive esophageal CA is more difficult in carcinoma caused by corrosive injury rather than de novo esophageal CA. Because these patients have already been suffering with dysphagia for a long period of time, so their symptoms may be attributed to the symptoms that they already have been complaining for a long period of time. And so clinically, it is very important for any new dysphagia or any worsening of dysphagia and weight loss to be alarming sign of development of malignant transformation. Endoscopic evaluation and surveillance plays the main role in diagnostic esophageal CA. However, some literature shows its limited role. And the occurrence of cancer is in the areas of narrowing and stenosis. Therefore, it is in these places that the endoscopists must focus their attention in order to look for pre-cancerous lesions and biopsy for the diagnosis. Newer techniques like endoscopy and neurobed imaging increase the yield of detection of carcinoma. Benacci et al. In his study of patients with severe acoustic stenosis, all the patients underwent lugol iodine endoscopy and neurobed imaging, and he concluded that the general acuity of the exam was 73%. So all the suspicion lesions, biopsy was taken, and he said that all the lesions were at the narrowing or at the stenotic site. So this is a case report by Jun Zhang et al., who reported 61 years old male who had a sulfuric acid injection at the age of 3 years and presented 58 years later with severe dysphagia of grade 5. Initially, he had reported 1 year prior to this incident with mild dysphagia, which was ignored. And now he had presented grade 5 and significant weight loss. This is the barium wall of the patient, which shows a long stricture at the mid part of the esophagus. And for the same patient, the endoscopy, it shows the luminal narrowing with no any suspected lesion around the narrowing. However, biopsies were taken which were negative for carcinoma. But because of worsening dysphagia, CT was done and the patient underwent esophagectomy. In the pathological specimen, he was found to have a T2 squamous cell carcinoma. So the reason for bringing up this case is to show that in esophageal CA caused by corrosive injury, one modality of investigation might not be enough. It needs a combination of modalities, and any clinical suspicion should be high for any worsening of dysphagia and weight loss. And because early detection leads to improved survival, it is important. So there was a paper by Seung Buno et al. In 2017 in Korea, who retrospectively studied all the patients who had severe corrosive injury from 1989 to 2015. And of these patients, those who developed esophageal carcinoma in the follow-up, he reviewed all the esophagograms and CT scans. However, this study is not very strong because it is a retrospective type of study and small sample size. But he concluded that esophagograms and CT scans play the predominant role in the diagnosis of esophageal CA secondary to corrosive injury. Where he showed that on esophagograms, 77% of the cancers were found at the stricture site. The most common morphological type was polypoid stricture. Mucosal irregularities were found in 92% of patients. The mean length of involvement was around 5 centimeters, and rigidity, that is, loss of esophageal mobility, was in about 69% of patients. CT findings showed eccentric wall thickening in 71% of patients, homogeneous enhancement in 69%, periosophageal infiltration in 79%, and the lymph nodes, either mediastinal or hilar, of more than 1 centimeter in 14% of patients. And these are some of the images from his study. This is a 49-year-old woman who had a history of sulfuric injection 23 years ago, who shows a sort of fungating mass at the mid portion of the esophagus with extension to the proximal part and circular dilatation just proximal to the stenosis. This is another 62-year-old lady with history of high ingestion, and the esophagogram showed that depression type of lesion just proximal to the stricture site with the convergence of the esophageal mucosa. And this is the resected specimen after Ivory Levis esophagectomy, which showed squamous cell carcinoma. This is a picture of 80-year-old lady who had, this is the same lady who had corrosive injury 40 years ago. This barium swallow was taken sometime before, showed a uniform small segment, uniform and small segment, and tapering narrowing at the proximal part of the esophagus, which was shown to be benign. After a few time, the same lady, there was a long stricture at the mid to distal part of the esophagus with sharp narrowing and irregular narrowing. It was diagnosed to be carcinoma. This is image of the CT scan showing esophageal wall thickening with periesophageal infiltration and homogeneous enhancement. Colonoscopy should be performed in all cases who are planned for surgery. Coming to the management of patients with esophageal CA secondary to corrosive injury, the main treatment modality is resection, esophagectomy. However, the literature records a reduced percentage of esophagectomies performed. Most of these patients undergo radiotherapy or combined therapy, radiochemotherapy, and palliative procedures as feeding tubes. Some authors, on one hand, recommend to prophylactically resect esophagus because in some of the studies, the prevalence of esophageal CA in patients with severe corrosive injury is shown to be high. For example, in the study by Kim et al., we showed about 13%. So this is a significant number of patients. And also, early surgery, prophylactic resection of the esophagus obviates the need for lifelong dilatations and risk of perforation. On the other hand, most of the authors, they avoid routine esophagectomies because they say that there is high risk of morbidity and mortality because of the significant fibrosis. And there is relatively lower risk of malignant transformation as shown in other studies. And those who support, and those patients who undergo bypass, there is even further reduction of the risk of malignant transformation because there is no stasis and there's no irritation of the mucosa, and carcinogenesis risk is reduced. So I think there are many experienced surgeons in this platform that will help us to. So this is a table which shows multiple publications from different parts of the country, from earlier periods to recent studies. We show the number of patients with corrosive injury, those who develop carcinoma, the time period from the injury to the diagnosis, the number of patients who undergo esophagectomy, and the 5-year survival. So only 2 studies I want to point here. That Kim et al. Study in Korea in 2001 showed that 13% prevalence of esophageal CA in patients with corrosive injury, and the time from injury to diagnosis was the shortest, 12 years. While in a study of Ruol et al. In Italy in 2010 showed the lowest prevalence of esophageal CA in severe corrosive stenosis of 0.8%, and the longest period from injury to occurrence. And number of esophagectomies are few. But in the later studies, it shows that the 5-year survival is about 50%. So prognosis, survival rate of patients with prostate injury is better than de novo esophageal CA. So 5-year survival is about 45 to 50%, and 10-year survival is about 10%. The prognosis of prostate injury-induced carcinoma is better because of some of the theories mentioned in literature. One of it is that because there is a fibrosis, the growth of the tumor, significant portion of the growth of the tumor is intraluminal, and therefore early worsening of dysphagia and can be picked up easily. The second thing is that these patients have lifelong dysphagia, and they undergo repeated endoscopies and dilatations, so they can be picked up earlier. The third thing is that the peritumoral intratumoral fibrosis limits the spread of the disease to adjacent organs and to lymph nodes, and therefore it has been shown to have a better prognosis than other forms of dysphagia. Lastly, I want to mention one of the study over here of Ruol et al. In 2010. He showed that of his resection of those patients diagnosed with dysphagia secondary to chronic prostate stenosis, sphiectomy was done in 68% of patients. The mortality rates was 40 and 40%. Morbidity and mortality rates was 40 and 4% respectively. The 5-year survival is 52%. And when comparing non-scar carcinoma to scar carcinoma, he showed that those with scar carcinoma had a significant peritumoral fibrosis, and this led to higher prevalence of tumors detected in the early stages, T1 and T2, and less lymph node metastasis, and this data were clinically significant. Then also the 5-year survival for patients with scar carcinoma was better in those who are resected and those who are not resected. So to summarize, there is increased risk of malignant neoplasm in prostate injury, recorded 3 to 4 decades after the injury. There is no gender preference. Smoking, alcoholism increases the risk of cancer. Also, reflux disease might increase the risk of cancer. Squamous cell carcinoma is the most prevalent histology and occurs mostly in the areas of stricture, mostly in the mid part of the esophagus. Diagnosis of neoplasia is difficult, and periodic endoscopic follow-up with biopsies is necessary for all patients with history of prostate ingestion, at least after a certain period of time, every 2 to 3 years, even if they do not present with dysphagia. Biopsy should be obtained close to the areas of stricture where neoplasm arise. Early diagnosis and treatment further improves 5 and 10-year survival, and prognosis is better than other forms of dysphagia. And there is high incidence of prostate injection in some countries, and this highlights the need for implementing prevention programs, adult education, and national database to further define properly the risk of of the incidence of esophageal cancer in such a group of patients. And finally, I want to thank the opportunity to present in this wonderful platform.
Yeah, thank you, Dr. Naushad, for your elaborative literature review on the topic of malignancy in the setting of corrosive injury. So I think we can start. Is Dr. Dash here?
Yes, he is there.
Yeah, please.
Yeah,
So yeah, now set the ball rolling.
I must congratulate Dr. Nishad in his first presentation. It was very elaborately dealt with, very nicely dealt with depth. I must admit that I had really I have attended many forum where people actually do not take this aspect of the corrosive structure, that is malignancy, very seriously. Whenever we start discussing, they say that it's a very old literature. We have never seen cases like this. But after your presentation, I think it tempts me to take the thing seriously and maybe more discuss about it. This has been a short question, and I think the students will be very benefited by your presentation. It's a complete coverage of the thing. Oh, what actually puzzles me is, number one, now how do we say that after 40 years the malignancy is not de novo and it's because of that, because of the scar? If we say it is a scar, Then from where the squamous cell tissue comes, scar is a fibrous tissue only. We can always say, if we compare or with the burn of the skin, then there occurs scar carcinoma or Marjolin's ulcer. Are these which are of good prognosis? So it could be because of it could be similar to that, from where it comes. That's what really puzzles me. And see, once a patient gets a corrosive injury, particularly if they are very high grade injuries, I'm not sure, particularly the pharyngoesophageal strictures. I haven't seen any report of malignancy occurring in pharyngoesophageal strictures, and the pharyngoesophageal stricture population, it's very difficult to survive for that long, 40 years or so after the injury and stricture, to have a malignancy. Then I think there are a lot of areas which are not answered, and maybe they have been masked by the fact that we ourselves haven't seen much of the cases. I personally haven't come across a single case during my 25-year career. But it was very nice, very nice. And I would suggest here that Dr. Professor Kapoor has a presentation where he presented. I do not remember exactly how to present. I think you should try to retrieve that presentation. It was in the internet, and it's very elaborately he has stated the nuances of presenting of presentation.